Okay, so it's an honor and pleasure to be here and to present today. And the topic of my talk will be dual diagnosis, one path. And I'm a psychologist, I'm a professor of clinical psychology and psychotherapy. This is why my focus is on psychosocial treatment and not medication. So, disclaimer, I'm giving advice if needed to different authorities. The German government just legalized cannabis last year, for example. I'm working for the European Drugs Agency, World Health Organization, and also the World Anti-Drug Agency in 2022. I'm the acting president of the German Society of Addiction Research and Therapy and second vice president of the European Federation of Addiction Societies. And I always get public funding. I have no link with any industry. It's important. So that's the overview of my presentation. I will first address why comorbidity matters so much. Epidemiology, pathways, and also treatment barriers are important to mention. Then I will have a focus on two common co-occurring disorders. The first is alcohol use disorder and depression, because it's so frequent and because we also have quite good evidence of what works in treatment. And the second condition is cannabis use disorder. We just had the beautiful talk from famous Professor Hustes. So I will address treatment of cannabis use disorders and psychosis. Why? Because it's well known that cannabis use worsens the cause of the comorbid psychosis. And I'll always have first a look at the epidemiology. I'll give a case example, someone I treated myself, and then we have a look at the treatment recommendations. What's the best evidence? What can we do? Then I give a summary. I have some outline, give you some online resources, and a take-home message. Yeah, why does comorbidity matter? We saw this picture earlier yesterday by Professor Suris and also mentioned by Marion Hustes. This is data from the World Drug Report. It's published annually in May, June. So this is data from the latest report, and you can see here in the past decade, cannabis use has increased globally. We have now more than 360 million people who used cannabis in the past year, and there was an increase of 18% in the past decade. So more and more people are using cannabis globally. And this is also data from the latest, 28% increase. Latest World Drug Report, most people are using cannabis, followed by opioids, amphetamines, cocaine, and ecstasy. But what is really important, and this is earlier data from the World Drug Report, the very big troublemakers are the legal drugs, especially tobacco and alcohol use as risk factors for substance use related death. So 95% of drug-related death account for alcohol and tobacco use, and 5% for drug use. And there's also data that healthy life gets lost due to disability and to premature death. And again, tobacco and alcohol are the big troublemakers. So we have really high health costs due to disability and premature death. And again, we saw this data yesterday. The number of people with drug use disorders is also increasing by 13% in the past decade. And we really see a large treatment gap in these people who are misusing or addicted to a substance. 1 in 7 men get treatment, and only 1 in 18 women. So there is a large treatment gap, especially around women. So, epidemiology. Substance use disorders, I mean misuse of alcohol or any other psychoactive drug, often occur simultaneously with another condition, with a psychiatric disorder. So according to the National Survey on Drug Use and Health, 17 million US adults experienced both conditions in the year 2020, substance use disorder and a mental health condition. And this can apply to a large range of mental disorders: mood disorder, depression, bipolar disorder, anxiety disorder, post-traumatic stress disorder, personality disorders, psychosis and schizophrenia, attention deficit hyperactivity disorder, and eating disorder. And this is also data from the National Epidemiologic Survey on Alcohol and Related Conditions, the NC-ADC, published in JAMA in 2015 by Grant and colleagues. And it's probably not so easy to see from your seats, but you can see here alcohol use disorders in the past 12 months, assessed by DSM-5, and also lifetime diagnosis. And we separate between a mild, a moderate, and severe diagnosis. And they also apply the DSM-5 to any other psychiatric disorder. And what we can see here is a high link between 12-month alcohol use disorder and any other drug use disorder, adjusted odds ratio 3.3, and that increases to 5.3 in severe alcohol use disorder. And if you have a look at the lifetime diagnosis, odds ratio even decreased to 6.4. And there's also a strong link between alcohol use disorder and nicotine use disorder, and especially to personality disorders, antisocial disorder or borderline personality disorder. Yeah, so why does comorbidity matter? There are complex pathways. WHO gives us a simple definition. It's provided in the ICD-11 clinical descriptions and diagnostic guidelines, and that says that comorbidity refers to more than one disorder in the same individual, either at the same time or in succession. That may be a bit too simple. There are several hypotheses why there may be a link between two conditions. The first hypothesis is the direct causal hypothesis. That means that a mental health condition is caused by a substance use disorder. For example, intoxication and withdrawal can induce a variety of mental health symptoms and disorders: depression, bipolar disorder, anxiety disorder, and so on. But the substance can also be used to relieve or cope with difficult emotions, unpleasant feelings. And this is the often described self-medication hypothesis. But there may be another pathway. It's called the indirect causal hypothesis. So that means that one condition affects an intermediary factor that again increases the likelihood of developing the second condition. So for example, substance use disorder reduces the likelihood for completing high school. And a poorer level of education may lead or contribute somehow later in life to further difficulties, for example, unemployment, that again increase the risk of further problems, for example, depression. And there is a third hypothesis. It's the common factor hypothesis. It's probably the most likely hypothesis. It's the common factor hypothesis. That means there are two conditions, they are co-occurring, and they may be explained by a third factor, for example, shared biological, psychological, social, or environmental risk factors. And there's also an interesting example in many longitudinal surveys childhood trauma or early childhood adversity is associated with alteration in gene expression that have been associated with the development of mental health conditions and substance use disorder. So this would be an example of a common factor. Yeah, why comorbidity matters also is that it's really challenging. So co-conditions can create a lot of harm. You can see here, for example, poor physical health, poor social occupational functioning, greater drug use severity, increased risk of self-harm and suicide, poor mental health, increased homelessness, increased risk of violence, and increased stress, and especially in relationships. I hear that a lot from my patients. So many doctors, psychotherapists say, oh, these patients are difficult to deal with. Or some say they are difficult to treat. And also another group says they are untreatable. I don't want to deal with this group of patients because the clinical profile is so severe. We see a heterogeneous clinical picture. It's volatile, and indeed often it is difficult to treat. Why? Because motivation to change can quickly change. One day my patient comes and says, Dr. Hoch, I want to quit cannabis, I want to do it now. And I said, listen, let's prepare it carefully. And the next week she said, oh, I'm fine, I'm good, no problem at all. So that can be a bit puzzling to a therapist. So also motivation for therapy can change from one week to another. We have many treatment attempts and also discontinuations. And so sometimes outpatient and inpatient stays follow one another over years. And a really big problem is, in my country, probably in your country too, that clinical settings are either specialized in the treatment of addiction or in the co-condition, the mental health condition. So people either get treatment for their addiction, and as a consequence, the second condition, sometimes it's also a third or fourth conditions, and not only mental health, but also physical health, where you remain inadequately treatment. And this is a huge risk for chronicity. So let's dive into one of my examples, alcohol use disorders and depression. One of my patients said the problems always flow to the top. He can drink, there may be a quick relief, but the problem isn't solved. Yeah, epidemiology, alcohol use disorders and depression often occur together in clinical samples and also in the general population. And there are estimates that up to 50% of patients with alcohol use disorders do develop a depressive disorder during their lifetime, and vice versa. 40% of patients with depression develop alcohol dependence. That seems a bit high, but that's what I found in the literature. And these co-occurring conditions lead to higher burden of disease, more absenteeism and loss of production in the workplace, higher use of healthcare system, higher morbidity and mortality. And clinical studies, treatment studies clearly demonstrated that patients with alcohol use disorder and co-occurring depression, they benefit from addiction treatment. Just as much as those without depression. Substance use is improved. General physical and mental health is improved. Global functioning is improved. But they show a more severe clinical picture. They benefit from substance use treatment, but they still have a poor clinical profile at treatment end. Why? Because the depression is not treated. So there is a good side to this, because treatment providers, they do exceptionally well to treat the addiction. But the problems associated with depression remain untreated. So this is my case study. This was Franz. He was one of my clients. He was 54 years old when he came to the first meeting. He was an engineer at a medium-sized company in Munich, the city where I work and live. And he was married and the father of 3 children, 8, 12, and 15 years old. And he had repeated psychiatric and psychotherapeutic treatment for his depression over 10 years. And he was currently presenting himself because he had problems in his marriage. And his mood got worse and worse, and there was a development of depression again. And he told me that he had problems sleeping through the night. He had those feelings of emptiness, and he was really exhausted. He couldn't get sleep, he couldn't rest. And so I asked him about his alcohol use, and he was surprised. He said, no one in 10 years ever asked about my alcohol use. And you know why I asked him? Because I could smell alcohol. So I asked him, how much do you drink? And he admitted that he had at least 1 bottle of wine a day in the past 12 months. And also symptoms of withdrawal, especially trembling when he couldn't drink, craving, and a neglect of interest. And this is why there were problems in the relationship. Because he neglected everything, his children, his wife, and also his physical sports activities. So what can we do then with Franz? How can we treat Franz? There are treatment recommendations from recent treatment guidelines. This is the German treatment guidelines, screening, diagnosis, and treatment of alcohol use disorders. It's quite comprehensive, published in 2021. And there is an older guideline from the UK, from NICE, published in 2011. And this is the first and very important recommendation. If you have someone with depression, make a screening. Make a screening for alcohol use and use the audit, the alcohol use disorder identification test. And this is a strong recommendation. A means very strong. Level of evidence, 1B means we have good clinical studies supporting this recommendation. And almost 100% of experts agreed to this recommendation. So this is the audit alcohol screening questionnaire. 10 brief questions and a cutoff of 8 or higher is a marker for cannabis use disorders, as said by WHO. There are national adaptations. For example, in Germany, we say it's far too high, so we have lower thresholds, 5 for men and 4 for women. So the next treatment recommendation is that you should screen all patients with alcohol use disorders for depression. Of course, that makes sense. So it should be done the earliest after the symptoms of intoxication and withdrawal have subsided. And depression can be induced by the substance use and withdrawal. So this should be considered if it's a real co-occurring depression or it's part of the withdrawal process. Yeah. And the third recommendation is that if you have someone with dual diagnosis, treatment needs to be more intensive. It should be provided with longer and more intensive treatment. And yeah, the fourth recommendation is that you should integrate treatments. You shouldn't do it one after another. When your depression is better, we will have a look at the alcohol or vice versa. First, you need to stop alcohol use, then we can treat your depression. That's very common in my country. That's even needed if you want to get outpatient psychotherapy. People need to stop their alcohol use to get antidepressant psychotherapy. But no, that's not the best way. It should be done at the same time, integrated, parallel. And if it's not possible, you should have someone who is managing the treatment, for example, a case manager. Yeah, and what is recommended by the literature? It's a combination of cognitive behavioral therapy and motivational enhancement therapy, because it helps people to adopt healthier drinking habits, and it helps to improve the depression at the same time. It's highly effective, and effectiveness for other therapy methods are unclear so far, so they cannot be recommended. What means integrated treatment? There are integrated treatment programs, and they use interventions at the same time. And what is very special about these treatment programs, they are really flexible. And they are really adopted and matched to someone's individual needs at this moment of time. So they're conducted at the same time, in the same setting, and also by the same therapist. So this is our approach in cognitive behavioral therapy, that we can change ourselves. Change is possible. It's a very good message to people who suffer maybe for a long time from their conditions. We can change our thoughts. We can change our behavior, and that will change our feelings. And we can start really a positive circle of change. But the problem is that people with substance use disorders, they are not so willing to change, because the drug gives something positive, an immediate relief, for example. And sometimes therapist is considered as someone who is taking away something good. So we need to establish motivation to change alcohol use disorder, and then people are able to progress with their depression also. So these are the therapeutic modules of integrated treatment programs. Motivational enhancement therapy to strengthen motivation to change, to find treatment goal, what is the adequate goal for you, to promote change. And cognitive behavioral therapy are all the tools to do it. So to set your goal, to learn skills, how to stop, how to deal with craving, our difficult emotions, to become more active, to learn to solve your problems, not use the drug anymore, but really solve it. Learn to communicate your needs, how to say no, for example. And altogether learn to lead a satisfying life without drugs. Contingency management helps to stabilize any change. And relapse prevention is important to not go back to substance use again. Family therapy can be very helpful to include all family members, relatives. And of course, there is special intervention for co-occurring conditions that are especially helpful. For example, exposure therapy for people with anxiety disorders and so on. And medication, that's not part of my talk today, of course, applies to many mental health conditions. So I think this is really important. This is a fundamental idea of addiction. And James Prochaska and Carlo Di Clemente, Marin, I don't know, did you meet them? I met them both. Really nice elderly men. James Prochaska, he died 3 or 4 years ago. And they fundamentally changed our concept of addiction. Before, it was the common concept that either someone is willing to change or not motivated to change. And they had another thought, that it's like a circle, that you can establish change from a stage of pre-contemplation where someone says, no, not me, I'm fine, I'm good, I don't drink enough, I drink it, it's no drinking problem, to the next stage, maybe me, maybe there are things I would like to change, my wife is always discussing, I'm drinking too much, maybe could be better the relationship, yeah. So the next step is preparation. I really want to do something now. I want to prepare myself. I want to get ready. And the fourth stage is let's do this. Yeah, let's come to action. And fifth stage, it is possible. Change is possible. And there's always the risk of relapse. That's a common nature of addiction. So you can fall back from all of these stages to an earlier stage, but still you are always learning. If you relapse, it's not bad because you can have another try. You learn more, you know more, you get wiser. And one day you'll do it. I say to my patients, everybody can do it. Okay, so the next really important element of motivation enhancement therapy is motivation interviewing. It's really cool. It's not just a technique, not just a combination technique. It's also a spirit, how we talk to our patients, how we see them. So we establish a partnership. We accept our patients, his or her views. We are with compassion. And we try to evoke change. And there are different types of questions where you can use open questions. This is what my students always have to learn, how to create open questions, affirmations, and reflections. And there's also this very interesting fourfold table from Marlett and Gordon. So people can consider what are their benefits from abstinence, short-term and long-term, and their disadvantage from abstinence, short-term and long-term. Or they can keep a diary to become experts of their substance use. When did I use it? Where? Who? With? How much money did I spend? And so on, to get insight, to learn more about the use of the drug. And this is in German. I'm sorry, this is part of one of my books. This is a functional analysis of behavior, so they can really learn and understand why they are using the drug. So is there a trigger? What are my reactions to the drug? Thoughts, feelings, my body, my behavior, and especially what are the consequences? Short-term positive consequences, long-term positive consequences, and also negative consequences. So they really get an expert for themselves. Now, that's cognitive behavioral therapy. It's about reconstructing our thinking. I think it's a very fascinating technique that many of us, we think about 60,000 thoughts a day, yeah, all of us, so we cannot stop thinking. And many of our thoughts are just rubbish. It just occurs. It's natural, yeah. And some of them we grab and we get to know and we may change. And we can use these techniques. We need to identify negative and inaccurate thoughts. We can notice how they affect our feelings, our emotions, our motivation. And we can challenge and replace these thoughts. And this is done in therapy. So we can do reality testing. Is it real what I'm thinking? Are there alternative explanations? Can I put it into another perspective? And is there better thinking toward my goal? So these are more components of cognitive behavioral therapy, and you can see here there are treatment manuals you can use. So how to deal with symptoms of withdrawal, craving, how to create relaxation, pleasant activities, social competence, problem solving, how to manage stress, how to deal with difficult emotions. And also contingency management is really effective. We have good clinical studies. And so the principle is that you reward, as a therapist, the desired behavior, or patients learn to reward themselves. And you can also establish therapy contracts. And it's interesting because the principle also helps with the comorbid depression. relapse prevention, find triggers for relapse, boredom, stress, have an emergency kit, develop your own emergency plan, learn to say no. This is difficult to all of us, but patients with substance use disorders especially, they come from treatment, they need their friends, drug using friends. It's very difficult, maybe very difficult to say no, that can be learned. So I showed you the key elements of cognitive behavioral therapy and motivation enhancement therapy. And it's very important that they are integrative, that they are flexible, that you always work on a positive therapeutic relationship to keep patient in treatment. And it should be done by one practitioner, one team, and one setting. And if necessary, do really, really small baby steps. We have evidence from clinical studies. This is meta-analysis from Helen Leiper in the Netherlands. And this meta-analysis showed small but significant effects for integrated treatment for both depressive symptoms as well as alcohol use. And it's very interesting, there seems to be a sleeper effect because at follow-up, the effects on alcohol increased. So it may take time for therapy to improve the substance use disorder. So next condition, cannabis use disorder and psychosis, epidemiology. We conducted a systematic review of 26 reviews. So it's a review of reviews, a really big study. It was commissioned by the German government. And we found a robust association between occasional cannabis use and intensive cannabis use and psychosis. So the more people are using cannabis, the more the odds increases for psychosis. And what Meredith mentioned earlier, there's really an effect on the age of psychosis onset. On average, it's about 2.7 years earlier. And there's a multinational study from Europe and Brazil. They found out that daily use of high-potency cannabis increased the risk of psychosis by 5 in comparison to low THC cannabis. It just doubled the risk, And very interesting also that cannabis doubled the risk of psychosis relapse. It's associated with stronger positive symptoms and longer stays in inpatient treatment. And also, interestingly, those people who stopped cannabis use when they had their psychosis, when they got abstinent, they didn't differ in the risk of relapse to those patients who never used cannabis. So that's a very important message to people in hospitals. And 95% of first episode psychosis patients come with cannabis use. So this is the meta-analysis published in the European Archives. And we did a more comprehensive review of the literature of both sides, cannabis risks and medicinal benefits. It's open access here and also in the European Archives if you are interested in more information about cannabis. So the case study, also one of my patients called Hannah, she was 22 years old. And she came to treatment because she felt somehow that her cannabis use got out of control. She used far too much. Yeah. She lived with her partner. She studied theater studies. She was a very nice and creative person. And then for several weeks after using cannabis, she felt bizarre, somehow separated from the environment. And she had the impression that something is in the bush, that people in the subway could read her mind, and she always felt watched, and that someone is after her. And she also heard whispering voices, and that scared her extremely. So would she withdraw socially? She wouldn't leave the house. So how to deal her? Treatment recommendation. We just completed the National Treatment Guidelines on Cannabis Use Disorders. Will be published 2 weeks now, December 1st. And so we have very little information on how to treat cannabis use disorders and psychosis. There's clearly a lack in evidence from clinical trials. So we had a statement from our experts how to do diagnosis and treatment. And the experts said that patients with these dual diagnoses should be treated according to the guidelines for psychosis or other psychiatric disorders because we don't have enough information on a better way to do it. A bit disappointing. But still it's guidance. So the second recommendation is that there is good evidence for psychotherapy of cannabis use disorder and psychosis. It's again a strong recommendation. Level of evidence is really high and 100% agreement experts. So we should combine motivational enhancement therapy and cognitive behavioral therapy, just as I showed you, to reduce the frequency of cannabis use and also improve psychosis. Yeah. And there's also evidence. This is a trial from Denmark, Hjorter, from 2012, and he created a specialized psychosocial treatment combining CBT and motivational enhancement plus treatment as usual. We compare it to treatment as usual. And you can see here in comparison to baseline benefits and post-treatment and follow-up for the intervention for days of cannabis use in the last month and standard joints in the last month, but these findings were not statistically significant. So there's a new interesting trial just published. It's a protocol just published earlier this year, a pilot trial of a mobile app combining treatment for young people with psychosis and cannabis. And the first result suggests that it's feasible and acceptable, but needs to be studied more. It's a Canadian consortium of researchers. And we do have a systematic review on evidence of integrated management from Carol Weidel. And it's interesting here that this combination of treatment approaches, psychotherapeutic intervention and pharmacology, may benefit a reduction in cannabis use and also improve psychotic symptoms. So this is a promising way, I think, we should follow. Again, we have integrated treatment manuals here, also in English. This one is in German, this one in English. They combine cognitive behavioral therapy for psychosis, motivational interviewing, relapse prevention. They also have a focus on trauma-informed care, so to recognize triggers and emotions, and also a recovery-oriented practice, empowerment, and also integration to the community. So one of these approaches was studied and published in the Deutsche Ärzteblatt. It showed a short-term reduction of cannabis use and higher satisfaction with treatment and more motivation to change. So, to sum up, I showed you that substance use and substance use disorders are increasing globally. They are accompanied by a high burden of disease due to mortality, morbidity. We see a large treatment gap in those with substance use disorders, especially in women. And we also see high frequency of the high frequency of substance use disorder and comorbidity are another barrier to treatment. So it gets more difficult to get adequate treatment. And there is still the separation between mental health care and addiction, and that often leads that people with dual diagnosis are not treated adequately or treated at all. And I showed you good scientific evidence and clinical recommendations that we should integrate treatment programs, that this treatment needs to be done by one practitioner in one team, in one setting, that the combination of motivation enhancement and cognitive behavioral therapy is promising, and you need to be flexible. You need to adapt it to patients' needs. And there are some nice online tools I want to show you. For example, we have here this toolkit published in the UK. We have here another toolkit published by Stanford University in the States. Very good website from Australia, comorbidity guidelines, webinars, worksheets, tools, links, you can find anything you need. And also the Dual Diagnosis Hub from the UK with many resources. So my take-home message is dual diagnosis, one path. Adopt a holistic approach that focusing on treating the person with mental illness. You can find my talk here, and I thank you for your attention. Any questions or comments? Yes.
I have several questions. First of all, I was interested that you always use the word psychosis and you never use the word schizophrenia. So you obviously separate those, and schizophrenia is a total disease. So the psychosis you're talking about comes basically from the cannabis, or they have vulnerability to psychosis and cannabis precipitates that? A little clarity here.
Yeah. I refer to the literature and to the studies and what was studied. And this was the concept of psychosis, and it's very difficult to tell, if why do they have psychosis. And we have, I believe in the concept of cannabis as a trigger in that combination with other stressors, so that cannabis may be a stressor and may trigger the psychosis, but we can see that there is a strong link. So it's even more important if there's also the onset of the disease to change the prognosis. So people stop using cannabis, and they can do so when they're in the clinic. When we see them, we can also motivate them to do so. So the course of the disease, of the secondary disease, will be much better.
Anybody else have a question?
You said for the first one that they needed to reward themselves and it was going good. What is a good reward for someone?
Sometimes people don't know. Someone who is using a drug for a long time is really focused on getting the drug, using the drug, recovering from the drug. And we also know that the brain changes, that there is a sensitivity to this special reward, for example, cannabis. And this is something you can find out. Do you remember your life before you used the drug? What made you happy? Okay, physical activity. So why not go out and run, or cycle, or what else makes you happy? This is part of the cognitive behavioral treatment.
So I had an interesting job to write a safety report on psilocybin. And when I started, I was 100% sure that psilocybin was not useful, not successful, someone shouldn't use it. And by the time I finished 350 articles, and I was a huge supporter of psilocybin for treatment in some individuals with the whole psychological treatment support, etc. And I think for some people it can be life-changing, And some people might need it once, some people might need it once a year, even once a month. But the side effects are so much less than the other antidepressant drugs. You're an expert in this area. What do you think?
I don't know clinical studies using that. You may know the literature better than I do. It can be possible. We should be open to new possibilities, treatment possibilities, but of course they should be safe. And we should use always the same methodology to assess effectiveness, study quality, to come to really objective solutions when we compare one drug to another. So I think this is important.
What I think is dangerous is it's been successful in this very important therapeutic setting, but now we have so many people microdosing with mushrooms, and we have no clinical studies showing effectiveness or danger or safety. But so many people are self-medicating.
And the same to cannabinoid and psychosis, for example. There is some emerging evidence that it may be antipsychotic. So it may be interesting for especially these patients with the cannabis use disorders and psychosis. And there are first trials, for example, from the UK, showing promising results using CBD for cannabis use disorders. So this could be a way to move forward. We need more research. Any comment or question?